Good morning, friends. I'm here back, the lone voice for contrast ultrasound. But going by but anyway, the hall is more or less filled. But my grouse is, leave alone the nephrologists or the students, the industry is also not very interested in promoting contrast ultrasound. I'm surprised, even for this meeting, to get them interested and to get the appropriate machine to demo, I had difficulty. Now, in this conference where we are all dealing with, how well to do transplant and how well to make organs survive for long, early recognition of graft dysfunction and intervening early will be a fantastic thing. And we have a lot of modalities, a lot of imaging techniques present. And right now we had many cases presented by Dr. Umesh and comments by Dr. Vail. B-mode imaging, Doppler, elastography, and so on. But I still feel that they are all not adequate. And although very good illustrative cases were presented where they picked up early and intervened and all that, but there will be situations where they are insensitive and you may not be able to differentiate between different types of graft dysfunction and even between normal and abnormal in some cases. So we are ever looking for newer techniques which are, you can do it repeatedly without any problem for the patient, without any issue of toxicity. And the word contrast generally rings a bell in nephrologists because they immediately think of iodine contrast and nephrotoxicity. But the contrast we are going to talk about is, will not do anything to the kidney. This is not iodine. So my intention here is to show you some pictures of contrast ultrasound where how it may help us to identify disease and different patterns, what I have seen. Although this is not fully validated, but if only some of you are stimulated by this, I'll be happy. So here, nothing like seeing a functioning graft, and for every nephrologist in the theater, and it can be equated to only interventional nephrologists who are doing angioplasties or AV fistulas when they have a good flow when they release the clamp, and it gives such a pleasure to see a functioning graft. But at the same time, it is very, very frustrating to have a dysfunctioning graft. And so evaluating and fixing the cause of renal dysfunction has to be, superior motive when you come across a case. And I believe that the present modalities are not adequate enough. They are good, but they are not adequate enough. So we are ever looking for newer ones because even now gold standard is renal biopsy. And why talk about the vascular perfusion, especially the microvascular perfusion? We know that up to 50% of rejection episodes are subclinical and occur without changes in standard parameters such as renal biochemistry and most of the imaging. So vasculopathy at the microvascular level may be the way we should be approaching this, whether it can identify early dysfunction happening in the grafts. And the existing modalities are not good enough to identify microvascular perfusion anomalies in these organs. So what is this contrast ultrasound? This is using microbubble based contrast agents. So these are, this has actually lowered the detection threshold of perfusion problems in the tissues, not only kidney, in many organs. And the present generation of microbubble contrast, they make use of very inert, poorly soluble, perfluorinated gases. Actually, their half-life is very short. It lasts only 3 to 5 minutes. And you are aware that how air bubbles are used by cardiologists to test, shunts, and which is cheap and you can do it just like that. But only thing is that comes only for one cycle, one cardiac cycle. It will go off, so you can't be keeping on injecting. So this is one which will last for 3 to 5 minutes. So you'll have your time to analyze the perfusion patterns and it is very inert. By 3 to 5 minutes, the bubbles will get burst and the gases will be released in the lungs and they go away. And I'll be telling you about the bubbles, not in detail. Actually, phospholipid monolayer is there, and inside we have this gases. It is often sulfur hexafluoride, and many of these machines have this capacity, but they are not much used. And traditionally, they use it for differentiating between benign and malignant tumors and other specialties. But in kidneys and especially transplant, it is underused, I think. Actually, we have an intention to demonstrate this contrast. I hope the machine which is available here does I'll be able to demonstrate well. So this is a sample. This is an ordinary contrast enhanced ultrasound. Do you have a pointer? Pointer. So once you see this doing it yourself, you'll be thrilled and you'll be hooked on. Seeing the perfusion of the major arteries, the segmental, interlobar, etc., and how the tissues get perfused. It will be as though you see RBCs, running between vessels and reaching the tissues. It's such a glorious thing to watch. So this is a normal study, and it is not only visual. See, visually you'll be able to appreciate some of the factors, but they're not good enough always to differentiate very subtle changes. So now we take the time intensity curves, the time taken to the contrast to achieve the maximum peak perfusion, and the time taken to decay. Which one is for? Okay. Yeah. So this is the time to peak, and this is the washout time, and this is how slowly or quickly it decays. So I've been watching many of these cases and trying to differentiate the values of this and get some formulas, and I have not fully satisfied with what I got so far, but I simply believe that much can be done in this. So this is a normal one, and this is the normal time intensity curve, and what I do is I take samples in both the vessel, somewhere in the segmental artery or somewhere near the hilum, and the tissue as periphery as possible, and try to take immediately you'll get both the values like this. And if you see a pattern differentiate, normally they happen simultaneously and the pattern is similar, one lies over the other, but whether there is display, separation of these graphs, or the rate at which the peak inflow goes and the decay comes, these things may be able to tell us something more. So this is another thing. You see that the microbubbles have entered very slowly. It has taken such a long time to reach the peak in the artery, and even much slower in the tissues. And there is a difference between the perfusion levels, the decibels level in both artery and the tissues. Actually, many of the studies in the literature, they talk only about the tissues. They don't talk about this. This I started doing this just to see the difference. If there is any more information we can get out of studying both these graphs. So this is obviously an abnormal one. This is actually a calcineurin inhibitor toxicity, very high levels, and you see that because of the vasoconstriction, I guess the intake by the arteries and the tissues even much more slower, and they stay. The washout is also slow, and the diagnosis given above are not very. It is empirical only, but these are cases and these are the patterns I could pick up. You see that there is a difference. In this case, the uptake is normal, decay is normal, but there is a difference between the area of curve between these two curves. And here there is a delay in the uptake, and there is a delay in washout also. And this was a case of TMI. Again here I see that the uptake in the artery is very sharp. Tissue is also okay, but it doesn't reach that level. But the decay is very slow in the tissue, whereas the contrast goes off quickly from the vessels, but it remained longer in the tissues. And this is a visual thing to see, a case of moderate ATN here and severe ATN on the other side. You see the contrast. It takes at least 3-4 cycles to reach the periphery. It pulsates. So that itself will tell you that there is some resistance, there is some interstitial edema, and because of the ATN, and And this is the CNA toxicity, not as severe as the one which I showed earlier. You see the Doppler looks innocuous, and the color Doppler and the B mode they're all more or less normal. But you see that the uptake is very slow and decay is also very slow. The first graph which I showed. And these are standard ones. Many people talk about the cortical necrosis and infarcts picked up by contrast, negative areas. So this is straightforward. And this is one of my recent cases last month. Parvus Tardus seen in a case of renal transplant. It's actually a transplant renal artery stenosis. And this was the contrast study. Why is it not playing? Okay, actually the uptake was more or less absent, the contrast uptake, because of the renal artery stenosis. But you see that the B mode is more or less normal. And this is post intervention. And this is the angiogram. You see the tight stenosis here, and the stent has been placed. And this is post transplant. And now the perfusion is great. So, and this was an unusual case because we had difficulty getting hold of renal stents, and we used cardiac stents, and this was discussed in one of the recent forums, Inform forum. So with this basic observations, I thought I should do some in-depth study of these patterns and try to identify patterns and some statistically significant method to differentiate between different causes of graft dysfunction. So this was a pilot study started earlier. Now the number has increased. So consecutive renal transplant presenting with graft dysfunction, and all those with vascular and urological complications were left out, and they all underwent. I do elastography as well, and so records we have all the modes, and the contrast methods we use. Each vial contains 5 ml. It costs around 8,000 rupees. So you can't be using it for each patient. So I use 1 to 1.5 ml and combine with some other patients so that you can subsidize and use it in more number of patients. And these are the parameters taken, which I already told. The maximal peak uptake, the speed with which it is taken, and the decay, and all this are, some of them are given in the de novo by the machine itself, but some of the other things I had to measure manually and make a big record, and these are the various causes of graft dysfunction. And we compared it with normal, and that was very easy, separating abnormal from normal, and that was not a big deal. Now, and you see the results were statistically significant for the time to peak and the area under the curve for the grafts. So normal versus subnormal was not difficult, but the various types of dysfunction, again, I tried to get some significant differences, but because of the small numbers, I could not get the significant values. So I went ahead with using, making a big Excel sheet with more than 25 parameters, the difference between the area of curve of the artery and the tissue and the time peak and the gradient of the uptake and so many things which this chart will go long actually, nearly 25 parameters, and I fed this into an AI tool, Manus, that gives perplexity and ChatGPT. They don't give the ultimate one. They say we can't go beyond this. This Manus is a Chinese thing. It gave me, and it made the slides also to Manus, MANUS. This is actually only a free version, and it used ANOVA, K-means, chart and clustering pattern, PCA visualization, so many things which many of them I don't even know. And with all that, it came out with some results. Measurement of time to peak of tissue uptake, more than the vessel uptake, was statistically different between. See, I had 6 types of graft dysfunction, but the numbers were small, so it took up only 3. One is ACMR, this is ATA or ATN, and this was transplant glomerulopathy with some chronicity. So it ignored the other 3 types because the numbers were small, and this is the significance it could show. Taking these 3, especially the time to peak of the tissue and also the measurement of area under curve of the tissue uptake, which was not less than 0.05 but close to significant. And the slides were also made by that AI software. And this is the cluster visualization, and the 3 groups it could separate out. And so it concluded that contrast enhanced ultrasound clearly identifies abnormal from normal, appears useful to identify graft dysfunction early, and underlying cause also, maybe with more parameters and more numbers, it should be possible soon. You need more. The important limitations with me is, see the number of cases. I do only 1 or 2 transplants per month. So, number of them getting dysfunction will be much less, and only cases with biopsy I have taken for study, and the time of biopsy and the time of the study, they should be temporally very close. No point doing biopsy today and doing the contrast study much later. But to make it cheaper, I had to club cases. So some of them there was a significant time gap. So all these were limitations in the study. But larger centers with more volume, I think they could do much more. And something new has been happening now. What is new? Now, beyond this conventional ultrasound, there are ultra-fast machines which are 300 times faster, and the acquisition is not done in one plane, but in multiple planes. So the frames per second is 30,000 and compared to the regular 100. So the images they give is super fine. And the normal studies, you see that the cortex doesn't go beyond this, but here it picks up. And if all these parameters were used, and if you can identify them early, so this is simply to show that the normal color Doppler is sensitive here, microvascular flow imaging, ultra resolution, as small as 20 micrometer vessels it can pick up. And now it gives all these measurements which I took manually. These newer machines can give all this automatically using its own calculations. It takes in wash-in time, wash-out time, time to peak, and all that. And more interestingly, they claim it is more or less equivalent to ultrasound localization microscopy. So that is the resolution which we are expecting. But again, see, there has been talk about this ultrasound, contrast enhanced ultrasound for quite some time. Some of these papers are 5-10 years old, and they were given good impressions only, but somehow it is not being taken up and studied further because of limitation of the machine availability and cost of the contrast. And again, this has to be done by nephrologists. I'm sure radiologists not going to be interested in this, spending time and looking for newer measuring tools and all those stuff. So some of us, preferably younger ones. And this less than micrometer, you see the perfusion so well. And actually, this machine was kept in my place for some 10 days, and some of the images were taken from our center. And now they claim they can count the number of glomerulus. See, these are all computer generated, so I don't say we should believe that. Then I asked, how can you count the number of glomerulus using these imaging techniques? They say, see, this to and fro motion of the contrast in the vessels. So generally, it will go from the hilum to the periphery in one direction, and the veins, it will come back. But there will be areas where it will go round and round. So they are the glomerular, situations where you have the glomerulus. So this computer program can count the areas where there is to and fro motion in the contrast movement, and they count the number of glomerulus, which may not be accurate, but this concept is good. And so we had opportunity to study some cases with some gap. You see that the creatinine has gone up from 2.1 to 3.5, and the parameters have changed. And here you see the count of the glomerulus they give. Where is that? Glomeruli number 180. The area the area of interest you mark, and you get the number of glomerulus. But I'll have to confess, this may be absolutely wrong also, but the concept appears interesting. So the potential uses for the future, glomeruli quantification, and they are able to measure the density of the vasculature at any given place. So when there is more fibrosis and the vessels go into, or even in calcineurin toxicity where there is vasoconstriction, the density of the vessels may look less. And they claim they can even measure the diameter of these vessels. Again, so early tachyrotoxicity, because of vasoconstriction, the diameter might go down. These are all my assumptions and postulates. And so more use, we may be able to come out with early recognition of all these things. Thank you.